So my talk today, tengo un problema col computer, nos encontramos. Okay? Okay. So the dark out of the box. What it means? Dark is always a procedure that, as I said before, is associated to keratoconus and to big bubble. This is not true. I made a list before, and I want to speak about this list now. Dark is the best procedures for any stromal disease. And there are various techniques, even if in my hand now the technique are two, big bubble and peeling off. But any condition can change your approach. And you can see that the indication of dark are many, starting from any kind of ectasia. For example, this is a keratoconus with a broken Descemet membrane. Mostly of the surgeons are doing PK because the Descemet is broken, where we can do deep anterior lamellar keratoplasty because the ruptures, as even my friend, where is he? Went out. Jose, he said that any ruptures can be fixed. So, which is the secret? We should work before in the area that is not broken, and only at the end, when we are deep enough, we will cut the part that is related to the area of rupture, and then we can suture the donor, and the results are very good, and you have self-endothelium, not endothelium rejection, and prognosis of survival graft that is more than 90%. So the other condition is keratoglobus. It's an ectasia where PK is absolutely not indicated. The results of PK are very bad, and the failure, it's more or less 65% in 2 years. But with a longer follow-up, any PK in keratoglobus could fail. So what we can do in this case? Absolutely, we have to do anterior lamellar keratoplasty. And this is the surgery. So we can use a very large trifine. In this case, it's 11.5. And I don't like to strip the tissue here because the recipient bed can be very weak and you can break everything. So look, you can manage the eventually fold that you can obtain because there is a very big disparity between donor and recipient of the curvature. But if you manage with the stitch, you can avoid even the folds. This is the post-op, and this is the other eye. So the patients had bilateral keratoglobus, and they asked to receive surgery even in the worst eye, that is this. And you see what happened at this point. I perforate. So I started again, I perforate again. Before to speak which is the approach, surgical approach here, we should examine some schema. You can see here that the donor is flatter and the recipient is steeper. There is a big disparity between donor and recipient. If we remember that we have a rupture and we try to do this kind of surgery, you can see that you have some folds that can make, I don't know why this doesn't work very well. So you can develop a rupture, and these ruptures can make an untreatable double chamber because the disparity can be fixed before that we try to put the donor. What can we do to fix this terrible complication? There is only one approach in my hand. We should copy from retina surgeon. What the surgeon do when they have disparity between retina and choroid, and they should attach the retina to the choroid. They cut the retina in the periphery. They do 360-degree cutting, and then finally the retina can be reattached to the choroid. We should do the same. So we can cut the recipient bed 360 degree and make like a self-dissect graft and attach this to an allograft, dark allograft, and we have this kind of graft that is I don't want this word. We put together donor bulk and self-dissect graft. So let's see the surgery now. So we went with scissors, preparing the self-endothelium graft. We saved this graft with some visco, removed all the stroma, iridectomy, preparing a dark graft, and gluing the self-endothelium with the dark donor. At this point, we can fix the donor to the recipient, and we have self-endothelium and dark allograft combination. This is the post-op. 1 day post-op, 40 days post-op, and this is late post-op. You can see that enormous keratoglobus has been fixed without changing its self-endothelium. Another kind of ectasia that we can see when the previous surgeon has done smaller PK, and you can have a recidiva of ectasia. What can we do? Mostly of us should do larger PK. Well, I suggest don't do larger PK because the risk of rejection become higher. If we only change the stroma, that is the previous donor, and we put another stroma from another donor, and we don't change the endothelium, there is an antigenetic difference between the previous endothelium and the second donation, that is the stroma. So this can reduce, in theory, the rejection, because the rejection always starts from stroma and try to kill endothelium. And the endothelium was okay. And why we have to change an endothelium that after 15 years is still working and never rejection in the past years? So this is the surgery that I suggest. You can debulk the tissue, and then we have to work in the center, not in the periphery. Because if we work in the periphery, it's easy that the previous donor can detach from the recipient bed. So we start from the center and we go in the periphery. We remove all the stroma. And in the peripheric part, we don't need to be very deep because we are out of 80 millimeter and the optical zone is safe and functional. So at this point, we can fix the donor. And this is the post-op. 1 day post-op. You see the recipient bed is 70 microns. 2 months post-op, 56 microns. And this is the topography of the patient and the recipient bed that become 50 micron. So just to say, because we are speaking out of the box, let's see some other case. Why the cementocele? We lost penetrating wound. Okay. Let's speak about the cementocele. The cementocele is a condition where a lot of doctors say, well, dark is difficult here, let's make PK. It's wrong. We can debulk first, and then always with the same spatula that is smooth, you can find the plane and dissect the stroma, and you can make a fantastic dark, because as Arminder well described in his paper written in 2013, I've read everything of you, Arminder. Well, and you know that this is a special plane where is able to contain the rupture of the descemetocele. This is the post-op. So another, here, the penetrating wound. Enrica is here. Okay, just postponed What can we do in this patient? He's 15 years old, penetrating wound in optical zone. Well, we can do dark. We always work first in the area where the cornea was not cutted. And when we arrive in the area of a previous perforation, we are doing dark after 1 year related to the trauma, and we can remove all the stroma and look the post-op. Sometimes he wants 2, 3. Okay. Let's go. Okay. This is the post-op. You can see here the area of perforation, and look the slit lamp now. How beautiful is the transparency of this tissue. Can you move this? Yes. Okay. So at this point, the patient has cataract as well. After 18 months, we decided to remove a cataract. Look at the result. It's very good results. It went from 20/200 with pinhole 20/30, but still 2,000 cells of endothelium, ready for cataract surgery. You can see the endothelium there. Cataract surgery. We are making large incision in the area of astigmatism, superior and inferior. So the implant the lens, and we were really very lucky, and the patient recovered everything. But this is very good, because these patients that is 16 years old that become 20 with this long story now has a dark and not a PK in his eye. This is published in European Journal of Ophthalmologists. And another very good indication are the infection, especially the active infection, but obviously even the leukoma after infection. About the active infection, I will speak more large tomorrow. I have a talk about this, but this is active infection. No, this is the leukoma, sorry, the active infection is there. We have seen these patients that he went everywhere. This is an infection. Everybody used million of antibiotic. Nobody tried to treat this case like an herpes infection. We went with acyclovir, systemic acyclovir, local prednisolone, Lotemax, and look after 5 months. So the infection reduced a lot. And finally, we decided to go to a keratoplasty. Which keratoplasty can we do in this case? With all this neovascularization. My opinion is that we only can do DALC, a very large DALC, and the approach cannot be big bubble because we don't know if we had perforation or not. So we went with layer by layer, but look what happened during surgery. So we did 9 millimeter incision with the bulked tissue. And when we were going deeper and deeper, we perforated. Well, we put the tissue, the donor, and the air in the anterior chamber. We were almost sure that surgery can be good. Look what happened after 9 days. Double chamber. Double chamber in this case is terrible. You cannot fix this double chamber because the recipient bed is tight, is not flexible like you have the recipient bed when you have a big bubble type 1 or type 2. So this is a great disparity between the donor and recipient. We should fix the disparity between to do any other thing, because if we just put air in anterior chamber, even if we put a big bubble of air, you can see that you are not fixing the disparity, and when the air disappears, the double chamber comes again. So what is the surgery here? The surgery is similar to the previous case, but we are not doing a 360-degree cut, but we are making the recipient bed like a tongue. So at 6 hours, a piece of the recipient bed remains attached to the cornea. Because the situation is different. He already has the donor sutured on the recipient bed. And, if we do this surgery, the recipient bed will become a tongue. A tongue can be flexible. At this point, we can put air in anterior chamber, and the tongue should attach to the donor tissue. And here is the surgery. See? We removed some stitches, and we cut the tissue, not 360 degree, almost. Probably 34 degree remain attached. And at the end, we put air in anterior chamber. And this is the post-op, 60-day post-op. And this is 1 year post-op. Don't forget the combination DALC, systemic acyclovir, and loteprednolol. This is the final result. So the other infection are the active infection. I mean the danger active infection, fungal or acanthamoeba infection. We should try always medical therapy first. But we don't have to lose time. We should be sure that medical therapy is working and the infection is reducing, because we know the etiology of the infection. We are doing targeted therapy, and the infection is becoming better and better. If we don't have this result, surgery can save the eye. And we don't have to do late PK, because late PK gives very bad result. We have to do early DALC. Obviously, we should be sure that medical therapy is not working. And we have a lot of advantages with this approach. See, this is an acanthamoeba. After 20 days, no answer, the infection grows, and we debulk the tissue, and we go with a smaller trephine. We shove the ring, the peripheric rim, and we change everything, gloves, instruments, and we go to prepare the deepest plane. How? With the peeling off technique. Because with the peeling off technique, we have the deepest plane that if the pathologist find free of infection, you know that your patient is safe. So this is the peeling off. We cut the periphery. We spend a bit of time to do this surgery, but finally, at the end, we were able to peel off the tissue and send this kind of tissue to the pathologist. Well, you don't find many pathologists that are happy to do this work. I only found one that is a good friend of mine since 20 years, and he works 500 kilometers far from me, but because he's my friend, he studied this tissue, and after 10 days, this is the result of the pathologist. So the central part still infective, we still with active infection, but deep margin and peripheral rim result empty, free of infection. This is very good because you can interrupt your therapy that has a lot of toxicity on the epithelium. Well, you should closely follow the patient because the lab can give you the result, probably is right, but if we follow the patients and we closely try to understand if really the infection is eradicated, is the right approach. Another great indication of the dark out of the box is when we are doing keratoplasty in ocular surface disease. Oh, this is another case. Let's go back. This is another case that you can have in your practice. For example, this patient is sure that he received a dark surgery from another surgeon. But if you look the OCT up, you see that the OCT, the recipient bed, is more or less 200 micron. When the recipient bed is 200 micron, the vision is not good. In fact, you can see that the vision there was 20/40. So in this case, you can reoperate the patient, as you can see here in this video. Come on. Can you start the video back there? Okay, thank you. Okay. So you remove the graft, and with this, always with the same spatula, we try to remove another 100 micron of tissue, or more, as you can see there. And this is the OCT of post-op. That is 41 microns, 44, 58, and the vision grows to 20, 25. There is someone that can tell me how this sometimes works, sometimes doesn't work? What? So the ocular surface disease is another condition. If you do PK, even after you have restored the ocular surface, the risk of rejection is higher related to other PK. So in this case, we should first restore. Can you go more? Yeah. See, up you have the recipient, the ocular surface disease. In up on the right is after conjunctival limbal autograft, and here the big bubble, big bubble type 2 because started from the periphery. Carefully, you can do dark even in big bubble type 2. And at the end, this is the result. Radial keratotomy, fortunately, we don't have too many patients with radial keratotomy. Even radial keratotomy with a cut that were perforating the stroma can be fixed with dark. Okay. Thank you. Same spatula. Nothing spectacular. You can remove all the stroma and let the patient with the dark and not with the PK. Last video, please. Last stromal dystrophy, you know that should be fixed with a dark and not with the PK. But this is a very old video, and you can see that we are not using peeling off yet, and we were doing layer by layer. Trying viscodissection, failed. But if you maintain your approach calm, you can finally arrive deep enough and remove all the stroma. So this is my talk. I always invite you to SIGSO. Thank you so much. And sorry if I insisted with video and with dark. But believe me, dark will change the life of your patients and your life, because all of us that has done many PK in our life, we know that any time that the patients come in our office, we have our heart that is going faster, and we are praying that nothing happened. If you have done dark, you don't have this discomfort. Thank you.